Rheumatoid arthritis, like lupus, is one of those diseases that ends up being more of a syndrome than it does a clinical presentation with a diagnosis. So what you need to be able to do is spot the clinical syndrome to make the diagnosis of rheumatoid arthritis and then know how to treat it. Let's start off with the pathology. We're in rheumatology, so not surprising, it's an autoimmune disease. And being an autoimmune disease, it has a predilection for women more so than men. And usually they're going to be a little bit older. The problem with rheumatoid arthritis is actually in the pannus formation. So these immune cells get into these joints, they form this pannus, and there's only a limited amount of space in the joint. So as the pannus grows, it begins to erode away at the joints. And those erosions are what cause problems. So the pannus formation leads to joint destruction. And in particular, what we're looking for is erosion. Right, and so these things are going to happen in all the joints that are involved in rheumatoid arthritis. This is frustrating because there's this black box, right, that says rheumatoid arthritis. And out the bottom comes the major diagnosis, RA. What goes into the box, though, is highly variable. So how you come up with a diagnosis isn't going to be with one diagnostic step. It's going to be a combination of clinical clues. So what you want to look at, first are the joints, morning stiffness, nodules, and then some lab tests. All right, so let's talk about each of these things. The joints, for whatever reason, the joints that RA has a predilection for are going to be the really small ones. Therefore, you should look for the small joints in the hands and feet. You've probably seen TV commercials where you see the old lady who can't open a jar because her hands don't work. And it's going to be the hands that get all bent and deformed. And that's the classic picture you'll see on the exam, is someone who has crooked, bent fingers. The hands and feet are the ones that RA goes after, and in order to make the diagnosis, there must be more than 3 joints involved. And RA is always symmetric. The thing about RA is that even though it goes after the hands, it must spare the DIPs. So you're going to see a picture on the test. The hands are going to be all messed up. Swan neck deformities going in different directions, all crooked. Inability to use them because they're so bent. But if you see the last knuckle involved, the DIPs, it's not RA. But then there's going to be morning stiffness. And morning stiffness, in order to be rheumatoid arthritis, needs to be greater than 60 minutes. And what we're doing here is trying to separate rheumatoid arthritis from regular old osteoarthritis. Old fingers get stiff, but generally it takes less than 60 minutes. And what you should remember is less than 30 osteo, greater than 60 rheumatoid, and in between is sort of this crossover gray area. Greater than 60 minutes to relieve the morning stiffness, RA. Less than 30 minutes, more likely to be osteo. And if you see them, the nodules. And this is a late finding, and so if you see them, it's pathognomonic, and if you biopsy them, what you'll see is cholesterol. You want to intervene on these patients far before they end up with nodules, so you should be looking more for the joints and the morning stiffness. You could do a blood test. Broad strokes. CCP better than RF. Details. The CCP is more specific for rheumatoid arthritis. That is, if it's positive, it's probably rheumatoid arthritis. The rheumatoid factor is terribly named. It is actually just an inflammatory mediator that happens to be associated with rheumatoid arthritis. It is sensitive for inflammation. If the rheumatoid factor is negative, it's probably not RA. But the way you should use this is if you get both tests and one of them is positive, it counts for the disease. CCP, more expensive, more specific. Rheumatoid factor, cheaper, more sensitive, Either one counts for the diagnosis. And then you can use the imaging. And the imaging you want to choose is X-rays. Remember, what you're looking for is the pannus formation causing erosions. So what you're looking for is erosions. And if you see the words periarticular osteopenia, that's a buzzword for this is RA. Now, let's go into a little more details. You can have non-erosive RA. But for the test at the M3 level, what you're looking for is the person with symmetric, messed up hands that spares the DIPs with morning stiffness, with either a CCP or an RF on the lab test that's positive, and X-rays showing erosions and periarticular osteopenia. That's how you make the diagnosis of RA. And then, once making the diagnosis, you'll have to treat it. And the treatment is with NSAIDs. This is for symptom control. And DMARDs, disease-modifying agents. Everybody gets this. And you can lead up to the biologics, which is used for severe disease. And then you got some steroids, which should be used only intermittently during flares. Okay, let's talk about each one of these. NSAIDs, it doesn't matter which one you pick, but generally what you're going to see is ibuprofen and meloxicam. The big thing here for NSAIDs is never monotherapy. And the way you'll get tricked is by someone having very mild rheumatoid arthritis. There's no joint destruction. They barely meet the criteria. You'll be tempted to say, well, let's just use the thing that comes first, NSAIDs. The thing is that NSAIDs, while they do control symptoms, they don't change the course of the disease. Therefore, if you make the diagnosis of rheumatoid arthritis, the patient gets put on a DMARD. What I want you to learn is methotrexate, RA, hydroxychloroquine, lupus. The problem is that we now have enough evidence where this makes a really good board question. We're going to come back to this at the end of the treatment section. What I want you to learn is methotrexate, RA, hydroxychloroquine, lupus. The biologics are going to be the TNF-alpha inhibitors. Hard to say, hard to remember. Just remember that they're there. It's infliximab, rituximab, and etanercept. When it comes to the TNF-alpha inhibitors, know that you use it in severe RA. Not everybody needs them, but when you use them, it usually works. But before you put them on a biologic, which is going to ruin their immune system, you must first make sure that they're adequately vaccinated before starting, otherwise the vaccine won't take, and you have to test for TB and ask if they've been to endemic areas of known fungi. If you start them on this medication and they've been TB exposed, it will flare. If they've been exposed to a fungus, their immune system is suppressing it now, but if you take away their immune system, it will pop up. And if you try to vaccinate somebody on one of these things, it's not going to do anything. And as far as steroids go, you're going to use prednisone. And prednisone should be used in life-threatening flares, but it's often used in acute flare-ups of pain, but short courses only because of the morbidity associated with prednisone: weight gain, obesity, diabetes, osteopenia. Let's come back and talk about the DMARDs. There are other options. I want you to remember methotrexate, rheumatoid arthritis, hydroxychloroquine, lupus. But here's the truth. Methotrexate is the first-line agent for rheumatoid arthritis. If you can't use methotrexate, you should use leflunomide. You should also attempt to combine DMARDs before progressing to biologics. So methotrexate plus hydroxychloroquine and sulfasalazine is a legitimate regimen. Methotrexate is first, leflunomide if you can't use methotrexate, and then hydroxychloroquine in certain circumstances. Those circumstances are pregnancy, where methotrexate and leflunomide are contraindicated, as well as non-erosive disease, something that's very mild. Sulfasalazine is technically just as good as hydroxychloroquine, but you should see it as the third-line agent only with additive effects. Let's go through it one more time for the treatment. Methotrexate is first. Leflunomide is second. If you can't use methotrexate, it's the alternative. If you need to add on something, add on hydroxychloroquine. If you need to add on something else, add on the agent sulfasalazine. If they're pregnant or have non-erosive disease, you can start with hydroxychloroquine. I know that's a lot of words, and the medications are not easy to say, so what I want you to remember is methotrexate RA, hydroxychloroquine, lupus. But then there's something you can get some bonus points on the test for. If you hear morning stiffness and the spine, you might be tempted to think of ankylosing spondylitis. But if what you get is morning stiffness plus C1 and C2, something to do with the cervical spine, that's RA, and what you should do is get the x-ray. This is going to be the person who's going to go to surgery. They need a preoperative x-ray of the neck. Or they're going to show you an x-ray of the neck and give you the history of rheumatoid arthritis. Just know that those link together. The last thing is Felty syndrome. Super low yield. Rheumatoid arthritis plus neutropenia plus splenomegaly. Okay, what do you really need to know from this? Lots of joints, hands and feet, symmetrical. Greater than 60 minutes, morning stiffness. Erosions and periarticular osteopenia, CCP better than RF. If you're going to treat somebody, put on methotrexate, treat symptoms with NSAIDs, go to biologics only if it's really bad, and steroids almost never, except in an acute flare. That's rheumatoid arthritis.